Okay, as we move to our final session today, actually our second last session today, because we have tables discussion after that, we're going to be focusing in now on primary care response. And the one thing we know about primary care is the word diversity. Diverse settings, diverse professionals involving both complementary and different skills. And the department has assembled a panel here that reflects that level of diversity. I'll introduce them more formally when they get up to speak, but in the meantime, if I could introduce, on my left, we have Associate Professor Andrew Block. To his left, we have Sofi Milenkovski and Samantha Smorgan and Dr. Anita Munoz, and I will introduce them one at a time. But in the meantime, I will call our first speaker, who is Associate Professor Andrew Block. He's an adjunct clinical associate professor and is a clinician leader with joint appointments in the Department of Medicine, School of Clinical Sciences at Monash Health, Monash University, and Monash Health. He is currently the program director for the Acute, Subacute, and Community program for Monash Health. This program encompasses 3 emergency departments, 3 general medicine and subacute services, and an extensive community health presence across the southeast of Melbourne. Andrew is a clinician, leader, researcher, and policy advisor for refugee and asylum seeker health in the southeast of Melbourne. His action-oriented research seeks to improve healthcare access for asylum seekers and refugees. He's passionate about the opportunities for innovation that a shift towards a community-based healthcare can provide. Associate Professor Block was developer and lead clinician for an educational program designed for disadvantaged and refugee secondary school students that now supports over 300 students each year through the final 4 years of secondary school. He was invited to speak on this project at the 2012 Berlin World Health Summit and the Monash University Employability Symposium. Please welcome Associate Professor Andrew Block.
Thank you, Ernie. Somebody's clearly been on Google. So look, I wanted to actually take a slightly different tack today. I wanted to get you to think a little differently about the challenges that we face in winter. I was reflecting when I was sitting there this morning on, I think it was the slide that Ed put up about showing the presentations across the emergency departments year on year and how they lift it in winter. And I'm sure my colleagues in the room that work in emergency departments across the health services of Victoria would attest that it never sort of really gets back down to where it was before that winter, does it? Things just, and I think that graph showed us that, and we're certainly experiencing that in the outer southeast of Melbourne, which obviously comprises the large part of our catchment. So there's something systematic going on that is worse in winter. Clearly the flu is a contributor to this, and it is as it should be that our response to flu is epidemiologically based because it's a transmittable and preventable illness. But there's a challenging iceberg effect that sits beneath that I think many of us would agree represents this burgeoning chronic disease burden in our community that often is made worse by flu. So to try and help you think a little differently from most of the ways we've been thinking about how we might tackle flu, I want to tell you a story that might actually elucidate some of the challenges that we all face. So imagine, if you will, with me, an 82-year-old lady, Eastern European lady, we'll call her Sophie. She lives in an outer southeastern suburb of Melbourne, say Cranbourne, and she lost her husband 5 years ago to cancer and lives alone, and she has 2 children. They're grown-up children with their own families and their own careers, and they live on the other sides of Melbourne. So it's a bit of a hike across with all of their commitments to see Sophie. And Sophie's got a number of chronic diseases, sounding familiar, I'm sure, already. She's got heart failure, she has rheumatoid arthritis, she's got diabetes that she takes medications for, and she's got a number of other issues, amongst which is the fact that she takes lots of tablets and she's not quite sure about which tablets to take, which is made worse by the fact that her vision's failing a little bit and her hearing's not so good. Sounding familiar? So we know that Sophie is, in terms of the hospital system and our outpatient ambulatory services, is very well managed, and she'll tell you that for the last few days she's not been feeling quite right, but she's got her appointment with the rheumatology clinic to look at amending her medications for her rheumatoid arthritis that she's been waiting 6 months for. and finally got an opportunity for her son to pick her up and take her to the clinic. But she wasn't really feeling right. She's been off for a few days, she's been off her food, and she might have muddled some of her medications. So she goes to the rheumatoid outpatient clinic appointment and gets excellent care. The problem sitting beneath it is that it's not always apparent to the clinicians is that her diabetes is getting out of control, but she's been seen by the rheumatologist for her rheumatoid arthritis and had appropriate changes made. Then, because that was the one opportunity the son had to take her to her medical care, she doesn't see him for some time. And the ensuing week she gets more and more unwell and wants to see her GP, but she sort of doesn't really want to bother her GP because it doesn't seem like it's that bad, and it's a bit of a hike. A great GP who's got a very good care plan for her, but she has an issue in terms of socialisation and actually getting to the GP. And what happens one night, she's feeling dreadfully unwell and starts vomiting and dizzy, and she rings an ambulance, and in she comes. And she may or may not have the flu. We would hope that her GP has caught up with her vaccination, which in the majority of cases we do very, very well. But there's a burgeoning chronic disease behind this and isolation that is often made worse for a whole lot of reasons during winter. So two initiatives that Monash has invested a lot in, and I think challenges us to think about how, as health services, we can identify the partners that we may need to work with in getting ahead of this curve. So that it isn't just about winter and flu, it's about the fact that, yeah, we need to gear up our systems within the hospital service to be as efficient as possible, but we can start to identify patients and clients in the community who are at risk of decline. And I like very much this concept of identifying patients at risk. So the two initiatives that we're putting a lot of effort into are the Health Links Chronic Care that many of you would know about, which is this. I commend the department in freeing up the use of the WEAST funding for hospital services to start thinking about how they can invest that funding in a different way that reaches out and touches people and checks on them and prods them. So many of you would know that it's a system that's being piloted across a number of networks. And our network has only had about 400 patients, so not a huge number, but already in that 12 to 18 month period, we've reduced the hospitalisation of these patients by 5% and made a 25% reduction in their bed day usage for their chronic illnesses. So there's a really good example of the health services thinking about how can they reach out into the community. And the other area that I would offer up for you to think about is the area of refugee health and asylum seeker health, which you've heard I've got a confessed passion for. You know, that's a service journey over 7 years that's been in partnership with our primary health network in the southeast and their forerunner, the Medicare Local. And that was an excellent model of partnership of the Medicare Local and PHN bringing the primary care skill sets and some of the home touch services to the client, and then we can partner and support the GP, support the nurse that visits the home, and make sure that they've got access to language services, transport and socialisation. So I'm going to stop there and just leave you with that. The message I'd like to send is, as health services, start thinking about how we can get ahead of this wave and how we can partner to do that. Thank you.
Thank you very much, Andrew. Our next speaker on the panel is Sofi Milenkovski. Sofi has over 22 years of nursing and management experience. She's worked in various positions at Royal Melbourne Hospital and Western Health since the start of her career in 1996. Among dozens of projects she was involved in at Western Health, Sofi was a key stakeholder in reviewing and enhancing Western Hospital's home program, as well as implementing the medical ambulatory day unit and the discharge area. Sofi has a master's degree in community, family, and child health, and working within the community has always been her passion. She currently works at IPC Health as manager of clinical operations, which oversees GPs, pediatricians, infectious diseases practice nurses, youth and women's health, living well, refugee health, diabetic nurse education, and the heart program. So basically she has lots of time on her hands to do basically nothing. So please welcome Sofi Milenkovski.
Thank you, everyone. Oh, I'll just get on the. Okay, so first of all, I just want to let you know what IPC Health is. An actual community health organisation within the Melbourne's West, and it operates over 6 sites. We have 3 GP clinics. Sorry, that's not where it was going. So 3 GP clinics that are situated in Deer Park, Hoppers Crossing and Wyndham Vale. This is the first year that IPC Health has developed a winter planning strategy. In doing so, we thought, what can we do in the community to assist our clients and their families, as well as assist the demand placed on hospitals during this time? We came up with 2 areas we could assist in and hopefully make a difference. So the first one is in admission avoidance, and 2 around infection prevention. So IPC Health has planned to support the hospitals in admission avoidance by extending hours in operation to the GP clinics during the week and on the weekend. The clinic will also ascertain vulnerable clients at risk to support their care by scheduling regular appointments to see the GP during this time to assist in trying to avoid hospital admissions. We're also going to try and plan to work with Western Health Hospital in the Home to provide education to our GP clinic staff on the process to actually directly refer into Hospital in the Home program for clients that fit within their service, instead of actually transferring these clients into the ED department. Around infection prevention, IPC Health is intending to develop a GP home visit program to support vulnerable patients where appropriate and clinically indicated to reduce the risk of spreading infection to others. IPC Health promotes the flu vaccination program every year, and we will do so again this year. We will be introducing flu vaccination clinics, and they will be offered over a 3-week block period to the community from mid-April, as well as site clinics for staff vaccinations. We're intending to target at least around 100% of IPC Health staff all being vaccinated. I know that's a bit of a stretch. So we also actually promote infection control programs and emphasise the importance of hand hygiene. So in particular, it's effective hand washing techniques. So we will be expecting that 100% of our staff complete their hand hygiene competency to assist in minimising the actual spread of infection to our clients. All our staff will be promoting key messages on how to stay healthy this winter, as a focus in their consultations, as well as increasing information to clients and their families on minimising the risk of the spread of infection during the winter months. As I stated, this is the first year IPC Health has developed a winter planning strategy other than the flu vaccinations. We're hoping to actually work this as a project and collect some data so that we can actually analyse what has worked and what improvements or additions we can make for the following years. So we're hoping to work with Western Health and Werribee Mercy ED departments to assist us in promoting what we're actually wanting to do out in the community. So that's it.
Thank you very much, Sophie, and you'll have opportunities, obviously, to ask both Andrew and Sophie and our 2 other speakers questions at the end. But it does take us to our 3rd speaker, who is Samantha Smorgan. Samantha is the Director of Primary Care Practice at Northwestern Melbourne PHN. She has had over 12 years' experience in supporting primary care and specifically general practice. This has included time at the Royal Australian College of General Practitioners, working with standards and advocacy, as well as within the National Continuing Professional Development Program. Samantha's experience extends across a broad range of program areas, including systems change, representation of the primary care provider's perspective in research, health promotion, and other foundational initiatives. Please welcome Samantha Smorgan.
Thank you, and my slide as well. Thank you. So it's interesting to hear about the diversity of the colleagues that work within the sector that we work within. So how many people in here actually know what a primary health network is? Oh, more than I thought. Great. So just a bit of background, and it's a little bit of Groundhog Day, and I'm listening to the services themselves describe what it is that they do, and ultimately what we are looking to do is from a systems perspective and actually starting to work with all of the stakeholders that contribute to better health outcomes for the primary care, well, for the community, but via the primary care sector, and obviously trying to keep people out of hospital. So it's very much about the efficiency and effectiveness of the system and also appropriate care, so the right place at the right time. Just to give you a bit of a background on the challenge of the systems that we're working within, you can see from the snapshot up there of the map, it's actually quite a small area geographically. It is 13 local governments who all do things a little bit differently, and so trying to understand how we can support and work with them has been an interesting journey. But we also have a lot of the state-based specialist hospitals, and so a lot of the community that are coming into our sector actually don't live within us. And all of their healthcare providers actually sit outside of our region as well. So for us, it's really about communication and collaboration with all parts of the healthcare sector to actually understand when people are coming into the Royal Children's Hospital, for example, in their child's in a influenza state, what we can do to actually work with our colleagues across the rest of Victoria to actually implement better systems and processes so that that child can be cared for in the community. So this is sort of the slide on the winter planning, and it looks quite simple, but I'll try and go into some of the detail there. So our usual business and the business of my team as the primary care practice engagement team is very much about working with our 550 general practices to establish systems and processes that actually help to support giving patients the best care to avoid situations like we had last winter and the influenza outbreak. So that means the usual promotion of the changes to the national vaccination schedule. It's about establishing and doing continuing professional development and education to those practice teams about how they can set up systems to identify vulnerable members of their community. Obviously the older adult population, but obviously also the children and people with chronic diseases, so those most at risk of contracting these vaccine preventable diseases. We also work with the Department of Health and Human Services in regard to cold chain breaches and what we can actually do to support the viability and the potency of those vaccines, as well as education and training on personal protective equipment, putting it on and taking it off. Then there's the communication channels, so what actually we use to get out to all of our primary care stakeholders to inform them of what's going on, including health alerts from the Chief Health Officer, as well as any sort of responses that are required in an emergency situation. And to that end, we actually do a call for volunteers within our primary care community to indicate whether or not they're actually prepared to be available in the event of an emergency. And you know, pandemics and influenza and epidemics is certainly one of those things that they can nominate to become a flu site if that's what needs to happen, or if they're, you know, obviously finding that they're getting a lot of patients that are coming to their practices that are showing signs of influenza in this case, what we can do to help support them manage that load and how we can potentially expand the services that they have with those other providers that are willing to assist in the event of an emergency. We also have it's a social marketing campaign. It's called Immunise Melbourne. It's going into its 4th year, and it certainly this year does have a focus on winter planning. We understand, and I did miss the morning session, so I'm very much looking forward to catching up about what the department is doing to increase awareness in the community of influenza and the need to have their vaccinations done in time. But also thinking about all those other things that actually happen to our vulnerable populations in residential aged care and those isolated in the community around other infections that are avoidable during the winter months. So, you know, the incidence of shingles increases, the incidence of pneumonia, and we can actually promote the vaccination and the importance of those within general practice and primary care settings as well. So Immunise Melbourne this year is very much looking to understand what the department's doing and then look at how we can complement the messaging, and the target audience is very much about the hesitant vaccinations and whether or not it's the parents of kids or whether or not it's the carers of the elderly. Those that aren't sure are a little bit tentative. It gives those really those community-based voices to actually help understand what influences change. And we do get a lot of anti-vaxxers coming onto our Facebook page, and we try and, you know, bamboozle them with the facts, but it's something that we think is really important to actually have the voice of community tell their stories about why vaccination and preparing for flu season or winter planning is so important. That's us.
Thank you, Samantha. And to our final speaker on the panel, we have Dr. Anita Munoz. Anita graduated from Monash University in 2002 with honors and became a fellow of the Royal Australian College of General Practitioners in 2007. Anita completed a graduate certificate in clinical teaching at the University of Melbourne in 2016, and she has particular interest in women's health, chronic disease management, preventative medicine, travel medicine, and weight management. Anita is a medical educator for the MCCC GP training, where she teaches GP registrars working towards their fellowships in general practice. She is a general practice supervisor for students from the University of Melbourne and is an examiner for the Royal Australian College of General Practitioners. Anita is also a clinical editor working for the Inner Northwest Melbourne Medicare Local on the Health Pathways Project and sits on the Emerging Clinical Leaders Committee for Better Care Victoria. Please welcome Dr. Anita Munoz.
Do you mind if we put my, thank you. Thank you very much. So facing winter in general practice has got some controversies, as you may well imagine. And I'm pleased to have the opportunity to discuss what the reality of managing winter in general practice is like. I'd like to start with talking about the vaccine itself. Last year was a difficult year, as you know. It was one of the worst flu seasons that we've had in a while. And I guess it put the use of the vaccine under the spotlight. And I know certainly quite a few GPs that I've had some discussions with have questioned the vaccine from an academic point of view, and that discussion continues. So the use of the vaccine, certainly from a GP's point of view, almost all GPs are very pro-vaccine. But there are some mixed messages about the vaccine in terms of what we're exposed to in the literature. And that is causing, you know, some issue about who to vaccinate and when. There's conflicting advice in terms of who we vaccinate from peak bodies and from the academics, as you can see on my slides. If we were to stick strictly with guidelines and stick with the Australian Immunisation Handbook, the suggestion really is that we're aiming for people that are most at risk to target with the vaccination. But of course, in terms of campaigning, we're really wanting to be vaccinating as many people as we possibly can. But on the other hand, if we're looking at efficacy and duration of the vaccine doesn't stack up too well. So in terms of academic literature and cost-benefit analysis, the vaccine, certainly in terms of what we saw last year, is not as great. And so from that point of view, you're getting mixed messages. I personally, of course, believe that we should be vaccinating as many people as we can, but there's a lot of debate about the vaccine that continues to rage. And I think peak bodies arguing about this leads to confusion in the minds of the people that are supposed to be executing the activity, and that's not helpful. I also think that the events of 2015 with the serious side effects in children with the bio-CSL vaccine caused enormous damage with the preparedness to administer vaccine in children in GPs. The federal government itself, the Department of Health, issued a warning to GPs in a statement that said that they would be personally, medico-legally liable for anything that happened to children. And I think that that's still ringing in the ears of GPs even to this day. So I think those things need to be borne in everybody's minds when we're trying to have campaigns about vaccinating against influenza. My other comment is about the timing of the vaccination. We're now examining efficacy and the duration of the efficacy of the vaccine, and certainly my college is suggesting that we delay the vaccine. That's confusing patients, and GPs and the college are prepared to take that advice and to delay the vaccine. And of course, we are being usurped by entrepreneurial activities in pharmacies that are then suggesting that we're not doing the right thing by our patients, and that pharmacies are the ones that are preparing to vaccinate patients and do the right things. And of course, then you're finding that the continuity of care of patients is being fragmented because patients are presenting to pharmacies to get the vaccines that GPs are withholding. So it's very complicated, and I find all of these mixed messages are creating confusion that's really unhelpful in us delivering good care and consistent care to patients. When I was asked to talk on this topic, the issue of the PCR came up and how this test is costing the taxpayer an enormous amount of money, and the suggestion came that this money is being spent in primary care primarily. I found that that's actually not the case, although the test does get ordered in primary care. The majority of the money that's being spent on this PCR is probably being spent in New South Wales, where the rapid PCR test has been rolled out as a standard in the emergency department across the state. But there is no doubt that the test does get used in primary care, and there's several reasons for that. One of the reasons is that the PCR gets marketed to general practitioners by pathology companies, and it gets marketed as basically no cost to the patient. As you can see on my slide, beside the word cost, it says Medicare rebatable. Well, if you call up a pathology company and ask what the cost is, you'll be put on hold for about 12 minutes, like I was, and then eventually they will tell you that it will cost the taxpayer $41.80, and if the patient doesn't have Medicare, they will charge them a private charge of $196. But having said all that, if you are inclined to use guidelines, and the majority of GPs are faithful to our guideline, which happens to be the therapeutic guidelines, they do say that there is a role for this test, that clinical signs and symptoms are more reliable if you are actually in the middle of an epidemic, and if not, use the test to back up your clinical signs and symptoms. And so the test does have a role. Australian prescriber described the test in 2009 as having public benefits that cannot be underestimated. The other thing that I would like to say, which I think doesn't get appreciated much in tertiary care, is the magnitude of patient expectations. Anecdotally speaking, I'm aware of a case in which a patient who was not given this test upon request for the diagnosis of influenza went to another clinician who offered them the test, then made a complaint against a practitioner for misdiagnosis of influenza, and went so far as to lodge a complaint with AHPRA, and of course now that is a formal investigation, as all things that go to AHPRA are. Of course, then we have management of influenza, and the management, as we know, of viral illnesses that aren't serious are, conservative management, and that's how it should be. Except, of course, if you have a high-risk patient. And this is where frustration abounds, because I, like a lot of my colleagues, like to read and follow guidelines, and the ETG, which most of us have open, really defines what high risk is, and it's children under 5 and people with chronic illnesses, as we've heard talked about, and people who are obese or have diabetes and Down syndrome, and Aboriginal and Torres Strait Islander people, and you should be using antivirals in those people, and yet that gets disparaged by our colleagues and the profession that we're over-treating influenza. But what we're actually doing is we're trying to keep people out of your hospitals. And I think there is a problem with a discord between all of the guidelines, because if you open various websites, everyone seems to have a different idea about how this should be done. And that's not helping, because it seems that you're damned if you do and you're damned if you don't in general practice. Finally, I'd just like to tell you what is the reality of general practice itself. Firstly, general practice is a business. It's a small business. And that business is getting harder and harder to sustain. And if you are a GP who's servicing the disadvantaged communities, where often the worst of the chronic health is, and people, as we've heard, for example, our vignette on Sophia, a patient like that, you will be running a business based on bulk billing. So in order to sustain your business, you will be running fast-paced general practice. It is very badly remunerated. You will get $37.05 for a consultation that lasts greater than 5 minutes. 40% of that will go to your practice, and then you will pay tax on what is left. So for you to stay afloat, you have to do high volume practice. And 40% of your consults will have 2 or more issues to be managed in a consult. So that's the harsh reality of general practice. And if you're female, you'll be doing that all the time. I'd also like to just mention that one of the initiatives to service our expanding population is that we do have doctors that have come to work in Australia that have not been afforded what I believe should be their right to specialist training in our specialty, which is the specialty of general practice. They are working ostensibly sort of with the title of general practitioner, but they have not been invested in with a fellowship in general practice. And they may be very, very highly trained clinicians in another specialty working in the community. So they often are doing the very diverse work that we do with fewer years of experience, and that puts a lot of pressure on them to work in what I think is actually a very difficult area of medicine. The other thing is too that patients are becoming less and less able to tolerate sensible medicine, which is doing not much and watchful, sensible waiting and reviewing in 2 days, or let's just see how you go. Having said all of that, I think we do this very well. 40.8% of influenza-like illnesses were seen by GPs in 2017. And I can assure you, not all of those went to hospital. So I think despite the difficult season we had, general practice did what it was good at, which was keeping patients in the community. So what can we do? What's my recommendation for winter 2018 from the point of view of general practice and primary care? I think we have to decide who we want to vaccinate, and I think we need one consistent message and sing from the one song sheet. I think we have to decide what the PCR is for and propagate that information, but accept that medicine is not black and white, and accept that there is a lot of pressure from patients for exact diagnoses, and that sometimes that is the best road in terms of sustaining good patient-clinician relationships. I think we really need good collateral for GPs to back up the opinions that we give them. There's a paucity of that. When we tell them about the vaccine or not testing or going home and conservative management, about not going to hospital, that it's not just the voice of one doctor, that it's actually the voice of the profession. And this point, more than any other point, I think, is don't disparage GPs. Don't know what happens in their consultations. But perhaps more than anything, the disparaging of GPs will drive your patients to your emergency departments because you are eroding the community respect for primary care and building the idea that the best medical care occurs in the hospitals and the patients will only go to hospitals when they are unwell. I think that we need to be unified when it comes to clinical guidelines on antivirals and be consistent in our definition of the high-risk patient. Thank you very much.
Great, thank you, Anita. And if I could now open the floor to questions from any of our panel members. I encourage you to do that. We have a bit of time to which to do that. Any questions? If I could kick it off, then I'll ask you a question. I mean, the first three speakers particularly talked about, reaching out into the community. And I'm interested to know that, have those efforts ever been turned down? If so, for what reasons? And how do you go about overcoming any resistance that you might encounter along the way in terms of reaching out and creating a more collaborative environment?
I'll say in the last couple of months we actually did reach out to one of the hospitals, and so it was Western Health in Hospital in the Home. Having the background as to what they could do, we were able to have two of our clients bypass the ED and be able to go straight into the Hospital in the Home program. And this was just by having the knowledge of how to go about and doing it. So hence why for our winter demand strategy, I'm saying we have to work together. Let's educate GPs out in the community as well as to what other services or how we can actually navigate through the system. I think everyone wants to work together and everyone wants to help each other out. I just think it's about how we communicate it. I don't think necessarily the primary health or community or the hospitals will, there's any kind of barriers. I think it's just about knowing who to go to and how to go about it, and that's all, really.
I get the sense that's easier said than done, though. Yeah. Do you have any questions from the floor, rather than just hearing me bang on? Any questions about any of the speakers? What can I do to entice you? Yes.
I think there's a lot of energy spent on immunization, but as we know in the last years, it's not just immunization, it's about immunity. Because I didn't see any information about that. It's about, this is a problem, that's not a problem, but actually the problem is beneath that, the chronic health, sorry, Sophie, the future.
Yeah, fine.
But it's about, to identify that as a primary health point of view, to educate that, how do you be healthy, it's about lifestyle, about, always sitting down too long, So, is there any answer to
that? You make the question was about, just for our people online, was about, I suppose, building resistance and strength within the individual and not just an immediate response or a knee-jerk response to influenza. Is that... Yeah. So from my perspective as a primary health network, that's a really good point, and that is also the other work that we look to do to keep people well and out of hospital. So obviously we support all of the primary care, in my case very much predominantly general practitioners and their teams, to actually work with priority population. So we do a lot of work on population health data and understanding what the needs of the community are, and then actually putting programs in place that actually work to build the health profile of the region, which then has the impact of more resilience and strength and a healthy lifestyle, or better chronic disease management, or working with culturally and linguistically diverse or refugee populations to actually improve their health outcomes, which then in turn potentially improves or reduces their likelihood of actually getting a transmittable disease.
I was just going to add to that. I think that's another reason why particularly high-risk patients benefit from being vaccinated by a general practitioner, because a visiting order is an opportunity not only to give that message but to stabilise the underlying condition.
Absolutely.
So that you're in the best possible condition. Yeah. And some of them might even consider travelling to the country.
Anita, I notice you're nodding your head in violent agreement there. Did you want to add anything to that?
Yeah, I think that that's part of the reason why we would prefer that patients come to see their GP for their vaccination and not have disconnected care and having a vaccine in the pharmacy and a missed opportunity for their preventive care. And I was going to mention also that I think a person with a chronic disease like Sophie would benefit from having a standing appointment with their GP rather than an appointment on an ADS-NEES basis, because a person with those kind of needs should be coming in to see their GP as a matter of course, because there is always work to do and there is always a need to be seeing that person, because I think I see my specialty as the specialty of preventive medicine and chronic illness. So that is how we maximise outcomes, is with constant contact.
So just to add to that, in fact, only this morning I had a discussion with our clinical leader in that space around the health links, chronic care, the outreach system I was talking about, to explore how we can use that service to place these patients in a time way in front of their GP for their vaccine, but also for that wellness check, not just to try and opportunistically vaccinate, which has been the sort of the lower hanging fruit approach, but actually to get them in front of their GPs. You know, from my perspective, it's about joining the system up. This is what we've got to do. You know, we've got all these great pockets of activity, we just haven't joined it up. And in order to join it up, one of the initiatives that comes to mind, I had a discussion with some of my Sempen friends this morning, and Andrew's over there, I see, around the healthcare homes trial, you know, and the pathways work. I think I heard in your CV, Anita, as well, you're working on. I think, you know, these are going to be some fantastic enablers about quick, efficient information exchange, opportunities to quickly compare notes and identify high-risk clients across health services, across not-for-profits working in the community that can be the driver or the visitor or the, you know, the checker in or the nurse that does the sugars, and the coordinating GP. It's about, you know, and not just seeing it from the health service moving into the community approach or primary care, you know, being educated. It's about the department, it's about all of us taking a patient-centric approach to this system that's got fantastic bits. It's just not joined up. And we've got to join it up so that we can manage people's longitudinal well-being and health and social well-being and meaning and interaction, etc. And we'll move those curves. But until we do that, we're not.
Any other questions? I actually think that's a great segue into our final session, because Andrew's call for, you know, really taking these great pockets of activity and making that something more widespread. I think that's a great catapult into the discussions we're about to have. But before we do that, if you could just thank each of our 4 speakers on the panel.